Recording. Welcome, everybody. Thank you and happy Friday. Thank you for coming along to our free webinar today. I wanted to have a little bit of a talk about, I just wanted to unpack a bit of the difference, when you might recognize, how to recognize when somebody might need a mealtime management plan, and how to recognize when somebody might need a food and nutrition plan. Two different things. Now I'm hearing myself. Maybe I'll just talk again. It seems to have gone.
Oh, good. Yeah.
Yeah, that's all good. All righty. So, look, I'll share the PowerPoint because obviously we all love a good PowerPoint. And share screen. There we go. And I'll just pop to my PowerPoint, pop it into presentation mode. Prezzo. I have to apologize. I've just got a new computer and I've gone to a Mac after not using one for probably 15 years. So just bear with me. I think I'm good. I did one on this last week, so it should be good. I don't know why it's asking me all that. I don't want it to ask me all that.
Timothy, she can
Whoa.
hear you.
Can't hear me. Can anybody else not hear me?
Of anyone else can't hear Gina.
If I'll put a different.
Yeah. Everyone else are hearing you fine.
Okay, it must be an audio setting on your side of the fence. So have a little fiddle around with your audio settings, a little click down button next to the microphone, usually the culprit. So see what you can do. Luckily, it's recorded. I'll give you a moment while you do that. No, I keep going. This keeps going. I just need to go right back to the beginning of this one. Here we go. We're good. How's your sound? Have you got your sound now? Has she given you the thumbs up yet?
Mhm.
Yes,
Yes,
good.
thank you.
Good. Lovely. Okay. All right. Yeah. So I've pulled this together because obviously with the auditing and training and things that I do, there's often and continually at this point, just a little bit of knowledge gap I get around uh, mealtime management requirements. And I don't think a lot of people know about kind of nutrition and food plans. Um, and I kind of go back to the system before the NDIS when I'm talking about the food and nutrition plan because it kind of got thrown out. The baby got thrown out with the bathwater when the NDIS came in, and those things sort of went out the door because the government left it up to everybody to figure out. And maybe they thought or assumed that they figure that out, but it's just not figure outable unless you're actually a health professional. So really felt it was a little bit unfair to throw everybody in the pool into the deep end, which is what I really think happened. And then you've got turnover of staff. So even when you have maybe trained someone, you're going to have to, provide more information. Maybe you yourself don't come from a health or human service background, and maybe you didn't really know much about disability services. So there's a variety of reasons why I see that gap in knowledge out there in the NDIS landscape. So that's the reason why we're here. So this is me. So behaviour support practitioner, postgraduate in ageing and disability. I was an NDIS commission auditor. I no longer like to play in that area. I think it's fraught with problems. But I do a lot of internal audits, and we feel we make a much bigger difference doing that as an organisation. So I come from a way back, my very first qualification was as a dental therapist. They're now called, I think they're called, renamed the whole sector, oral health therapists now. Um, and so I've got policy experience, auditing experience, and I like training, so I've got training experience. So let's have a little focus on this. Now, I'm not here to talk to you about something that speech therapists or dietitians should be speaking to you about. I'm here to help you to see and recognize and be able to pass that information on about how you would recognize if somebody should have a mealtime management plan. Because remember, not everyone is going to come to you with one. These things develop over time. Sometimes they are from birth or from early on in life or adulthood, but other times you're going to be around, you're going to be the people who are going to witness the emergence of a need for a mealtime management plan. Okay. So it's not about playing allied health professions. It's about the people on the floor and the people managing them and the owners of these businesses being equipped to know when something's not right. Okay. And that's all you can provide as anyone who's an unqualified. If you're not an allied health professional, then from a sensible perspective, what you can do is observe and report when something's wrong and make appropriate take appropriate actions at that time. So let's have a look. So recognizing when a mealtime management plan is needed. So the mealtime management plan is something that's written by a professional. Okay. Look, nurses can write some mealtime management plans. I don't think it's something that sits in their profession. But some of them get a bit feisty about the fact that they can. That's great. I'm sure there are lots that they can write, but they can't know everything about every type of mealtime management plan. So they are written by medical or allied health professionals. Um, so it is to ensure that somebody is going to have a safe experience. And look, we know that the Commission has brought out that training a couple of years ago, which is all about, people being able to enjoy their meals and not cough and splutter all over the place. And it's a sign of the issues around this sector that they should have to bring that training out. And it came out probably 10 years, literally, maybe more, of course, after the market opened up to, non-qualified people to run these services. And I don't say run speech therapy practice. I'm saying, it means that pretty much anyone can become an NDIS provider. Therefore, there's a knowledge tree that may not exist. The tops of those branches may be clipped off. You would employ a speech therapist if you were going to provide speech therapy, but it doesn't mean the owner of the business is. So that knowledge at the top of the tree, in comparison with the old system, is no longer there. So, it seemed very sad that it took that long to put that training together. I can see there's a whole lot of comments there. Maybe not comments, maybe it's just history, but I just thought I'd stop and say, is there anything anyone was saying that I should have known about?
No, it's all good.
All good. You'll tell
Yeah.
me when there is. Yeah, good. Okay. So we just want to make sure that people are having at the lower end safe and enjoyable meals, as quality meals that are suitable for them, and at that acute end, that if they've got a mealtime management plan, you want to make sure that you're following it. It's being reviewed by professionals, and also that you're always on the lookout for when something's not right and when the emergence of a need for that mealtime management plan is coming into sight. Okay. And there's a few things that you'd want to look for. The NDIS mealtime management policy, it does require us to talk about the things that you would be looking for. But it's seldom that you're going to find a support worker that's reading that. In fact, I found seldom that I'm going to find the owner of a business or a manager who reads that. So, we we were actually the first company to put together training in the NDIS sector. There wasn't any on the landscape back in 2019, and we put together a lot of training by turning the policies into modules, just at the least. That was just the bottom layer of just rolling that out first so that people could see that. So that's an easier way to help people to get the headline information that they need to know. So there are signs and symptoms, and the more you educate staff to be able to recognise that, the safer and more the safer and I was going to say more compliant. Compliance and quality are relatively married couples. Um, you're not a quality service just because you're compliant. Um, but if you're not a quality service, you're not going to be compliant. So there's a synergy there. So it's about recognizing certain things and having those mechanisms in place, but also the knowledge in the first instance that's continually rolled around so people can do that in service. So first of all, you're going to be looking for swallowing difficulties. Okay. Now you will have people that you will have picked up these things at their assessment, because certainly any good assessment and any assessment that is compliant with the NDIS quality and safety standards, it will ask in the assessment phase anything relating to swallowing difficulties, trying to find out if there's a mealtime management plan. It's not always possible at that point to find out that someone's got an emerging swallowing difficulty, but occasionally it could happen. That's the ongoing job of the staff that are caring for the person. Um, so yeah, you'll find out if someone's got a plan at a mealtime management plan professionally written at assessment time, but you may not find out much else. Um, so what you're looking for on the ground is you're looking for people who have trouble chewing or swallowing. They'll avoid certain foods that are hard to chew. That can be different for different people. Okay. Now you've also got to remember that there are many foods that are not dissolvable they're not broken down by saliva, and they don't dissolve as they travel down um, your throat. There are some foods that would you think about a fairy floss? It's going to dissolve in saliva. But you think about a nut, it's not going to dissolve. So it's a big choking hazard. Okay. So there are certain foods that lend themselves to more difficulty. Now, what happens is that you'll hear people. I mean, I think it's probably like 6 or 7 years ago now when I first started to get a real idea of how little skill there was in the sector. When, I think a provider was sitting with me telling me about someone coughing when they eat. And I went, have you done a double look at that? And they went, no, no. I went, do you know what that might mean? And they didn't know. And that's when I first realized that, really we need to focus on this. So the coughing and spluttering is a very clear sign that somebody's having some issues. And you do not have to have some disability to be able to be someone who's developing dysphagia. It happens to a lot of people just from aging, okay? And it doesn't have to be 70 or 80 or 90. It can happen in people's 50s or 40s. Um, you know, it isn't really age bound because there are certain factors that can contribute to this, which without having some lifelong disability in the first place or even a medical condition. Okay. So coughing, you're looking for coughing, gagging, clearing the throat all the time. Remember that not everyone has good communication skills. Not everyone that this is happening to is going to attribute it to something that they're eating. So you're the eyes and ears, and you need to be noticing. Your support workers need to be noticing what's going on, and it's really important to be present at meal times. Um, at its worst, you are going to hear gurgling coming from people's throats, and that hoarse voice. If you've ever had anything, put your hand up for me if you've had um, something go down your windpipe. So it's gone down the wrong pipe. Can you put your hand up if that's happened to you? Okay, there's one. How many have we got any more? Tell me how many hands up we get. And if you don't know how to use the hands up mechanism, just put your hand up make some sort of noise so I get a sense of how many people have had some food go down the wrong way. Because at the moment, I'm not really getting many hands up. That can't possibly, surely. Have we got any people saying that they have? Thank you, Tina. Thank you, Andrew. Here's another way of doing it. Can you put your hand up if you've never had food go down the wrong way? Might have assumed that there's like nobody actually in at their desk, that people have like signed in and they're not actually here.
We've got Sally and Wendy saying they have of
They have
that's right.
or
Let's
haven't.
They have.
They have, they have. Okay. So that's it. Everyone's saying they have. Nobody's saying to me it hasn't happened to them. Because,
Correct. Yeah, correct.
okay, good, good. Okay, so you all know what it's like. Imagine if that happened all the time, continually, and somebody just wasn't picking up on that. And you might be thinking that's impossible, but it's not impossible and it happens all the time. And that's very uncomfortable for somebody. Alrighty, so I'm just going to flick back here. I am in don't know what I'm doing mode with a Mac. Um, Back to my PowerPoint. Oh, lordy me. Changing computers, eh? It's a big deal. Yeah. So these are really important things. The coughing, the gagging, the clearing of the throat, all of that. And once a person gets to know that something didn't go well last time or 5 times before, they might start avoiding it, but they may not have the communication skills to tell you. Um, and it may have taken them a long time to be able to figure it out. Um, so we've talked about peanuts, we've talked about, I'm just trying to think, carrot doesn't dissolve and it gets stuck, very stuck. So you've got a range of foods that are quite awful when they go down the wrong way. But we can also have fluids going down the wrong way, and that's not nice either. Um, so keep a lookout and watch people, because that's the reason being is, and I can't, there's no other way to say it. Like, I don't mean it to come out in the wrong way, but everyone's being paid to do that. You're being paid to care, and that's what caring is. So keep a lookout, observe, make sure that people's well-being is okay. And if you see something, put it in the notes, so that if it's seen again, that hopefully people can use that aggregated information to understand that something's going on for this person. Um, the hoarse voice is a really horrible thing to have after it's happened in a severe way, because the lungs will start to make mucus, and that mucus will you need to keep on clearing. So you'll hear a whole lot of telltale signs that these things are happening for people. Pills can go down the wrong way. A lot of things eventually dissolve, but it can be very, 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 very uncomfortable. I had a medication go down. Look, I wasn't even old. I was probably in my 30s. And just one day, a medication went down the wrong hole. And might have been 40s, but no, late 30s. That's not old, is it? Went down the wrong hole. It was really horrible. And the amount of coughing, eventually my body did what it needed to do to get it up there, but it wasn't nice. And sometimes it'll come out people's noses as well, because remember that these passages, they have connections. So looking for all of that. And imagine being the person who doesn't have communication, or is in some stage of a dementia of some kind, or an acquired brain injury. Imagine if they can't really tell anyone to help them. So very, very unpleasant. When someone takes a really long time to finish their meal and they're just tired after it's done, other things to watch out for. Um, Food and saliva can be dribbling from someone's mouth. Watch out for those things because there are conditions, and there's no point going into the conditions because just watch out for the signs. There are conditions where there could be drooling, but I can also tell you that when you don't have enough teeth in your mouth, because obviously teeth are like a fence, and if there's a pool of saliva under your tongue and there's some missing teeth, there's a good chance it's going to dribble out. Can anyone tell me one of the other things that will happen if you've got missing teeth? Happy for your
Aspiration from
turn.
Robin.
Say it again.
We've got aspiration from Robin.
Well, absolutely, that will be the end product. But what will cause that? So if you've got
Yeah,
a few
food
missing teeth, what's likely to happen?
food food will not be chewed properly and can even
Correct.
drop off the mouth.
That's exactly right. So food can't be the word. Um, there's a word for chewing. It's called masticating. Food cannot be masticated properly. So we've got teeth at the back. They're called our molars. They do the grinding. They're the grinders. We've got teeth at the front. They're called incisors. They're called incisors because they do the biting. They will make a, a piece of food smaller. Yeah. And then we've got the ones in the middle as well, which are your premolars. They do a bit of grinding and a bit of tearing. And your eye teeth, which are a nice, that pointy one. You've got two front ones. So you've got two front ones here, second front ones, and then your eye teeth, which they call canines. That's not the real name. Well, actually, it is a real name. Eye teeth is another name for it because they're under your eye. They do ripping. Okay. Can you imagine if you don't have many of them? It's going to be difficult. All right. And if you've got pain in some of them, you're also not going to chew on them. So start to take notice of, and I'm going to talk about in supported independent living, the CHAP, the it doesn't even matter whether you use the official CHAP, as long as that person's going to the dentist, going to their GP, getting a list of what needs to be taken care of over the next year. And but I will say it should include a visit to the dentist every 6 months. Um, there will be people who won't want to have their dental health. It might be difficult. I've worked through all of that. When I first graduated, I was in a disability unit in on the Central Coast. They don't even exist anymore inside the schools. Um, there are going to be people who don't want to, but that doesn't mean you don't ask and you don't talk about that because without good dental health, you cannot get nutrition and you can't chew your food. And a lot of the result will often be um, some swallowing difficulties or swallowing food without it being chewed properly. So there's a range of things. You don't have to figure out uh, you don't have to figure out the reason or why the person's got some swallowing difficulties. All you need to do is look at all the signs and the symptoms and go, hey, I know this isn't looking comfortable or safe. Now, what I'll add to that, and I haven't found an update yet, but I've been looking for one, is the last research that came out, which was collected between 2013 and 2018. So it is right in the rollout. The NDIS was around. 10% of out of the preventable deaths, 10% of them were from aspiration pneumonia. So Robin, who just talked about aspiration, and I know you know what it is. So, and I know you, Robin. So why don't you tell everyone what aspiration is?
It's just swallowing of the items which can block the airway, leading to choking of that person and the
That's
gasping
right.
of breath. Yeah, in that way.
Yeah. Yeah. So aspiration is when it goes down that, I'm just going to use the word windpipe. instead of the food hole, and it blocks a person from air. Now that can move around, and that moment, and it's happened to me. It can move around, and you go, oh, I can't breathe for a second, and then it moves, and you can start to breathe a little bit. But sometimes, additionally, it will be the choking. It will be the choking that occurs, and perhaps death ensues. The other thing is that it goes down onto your lungs, and that's what we mean by aspiration pneumonia. So who wants to have a stab at what aspiration pneumonia is? Nobody? Okay, so pneumonia is obviously a respiratory illness where you've got a lot of infection, but the infection doesn't necessarily need to be caused by a virus or a bug. It can be started by a piece of food being stuck in that person's air pipes and going further down. So 10% of deaths that were preventable between 2013 and 2018 were through aspiration pneumonia. And that should be pretty sobering, because that's a pretty bloody horrible way to die. And I would have said this probably, I don't know if I would have said it 20 years ago. I'm 60 now. I don't know if I would have said it 20 years ago, but I definitely say it now as a bloody horrible way to go. So please take it really seriously. I don't know if your sole trader support workers in the room, or that will be watching this from at another time that didn't make it here today, and I will put this on YouTube as well. I don't know whether you're the frontline worker. I'm speaking to you if you are. If you're the team leader, I'm speaking to you. If you're the manager or compliance or quality manager, I'm speaking to you. And if you're the owner, I'm also speaking to you, because the buck stops with you as well. So really, this is the most unpleasant thing to happen to a person. So remember, teeth, illnesses, aging as well, it starts to occur. And then there's the food and liquid that can come out of people's noses. It's about the frequency of that. So watch it, document it, watch it, speak to your, senior people, do something about it for people. So I am saying that SIL is super important, because you're not in a SIL if there isn't a really good reason. But I'm also saying that if you're doing community care, taking people out, taking them to appointments, anytime when food is involved, it becomes relevant. You take on a bit more responsibility when food becomes involved with that care and the person. Okay. If you do see people that are getting these repeated chest infections, ask yourself, gosh, I do see them having a little bit of a cough and splutter. I do see, all of these things that I just, found out about might mean they're having an uncomfortable food time. So yeah, put two and two together and speak up. And when people have a medication where there's a side effect of drowsiness, do not go away from that table. Please read. These people would hopefully be on a medication management plan. I mean, this is where, oh, I've seen some of this. I've seen this in them and this in them, and I'll just check if they got mealtime management plans. And if they're not in that cohort of people that already do, it's time to speak up, yeah, and start saying something to someone who can do something about it by making a referral for an assessment. There is no harm in having an assessment and having that person, that allied health professional. And I wouldn't go to the GP. I'd get the allied health professional, just between you, me, and the garden post, because that's what they do. You find someone who does swallowing difficulties or mealtime plans. That's what they do. They're going to be good at it. So it doesn't matter, and you don't have anything to feel awful about if they go, yeah, there's nothing severe there now. It's just a bit, but we're going to keep an eye on it now. Okay, nothing wrong with that. That's perfect. That's lovely. That's helping somebody not, be one of that 10%. And we don't know how much more it is or less since 2018. But we do know the scheme's grown, and we do know that the providers have continued to grow at a 7% per quarter. So I don't know if it's going to be looking any prettier. So bottom line is here. Why it matters: unmanaged dysphagia can lead to choking, aspiration, so we know what aspiration is now, and serious illness. Escalate to your supervisor if you notice these things. If your person that is your supervisor or the owner of the business isn't listening, it doesn't leave you with much choice other than to make a complaint, okay? Because it's wrong. So you don't have to say, and I don't mean to the business, I mean you make it straight to the commission. If they're not listening, you have to act. So then you've got other types of, see, that's the serious, really serious, and I'm very uncomfortable. Then we've got food allergies and intolerance. They may not be something that came to you with a mealtime management plan, because these develop over time as well. So we've got, we will always try to, at an assessment, of course, mark as a red flag anything that people are allergic to, whatever they're intolerant to. But, be looking around to see, always looking. You probably know more about this than you might about the swallowing difficulties. I think that's probably a general assumption, but, because allergies are so prevalent these days, they weren't when I was a child. So, you want to be looking at rashes, hives, swelling of lips, after eating. For example, you can see that I have food intolerances and food allergies, because I have quite a bit of autoimmune issues, which is a lot better than it was 20 years ago. But I will break out with some foods. Someone will tell me there's no MSG in that, but by golly, my face will tell you a different story. Yeah. So some people will continue to break out. Now, would you keep giving someone MS, whatever it was that was doing that? It's very uncomfortable for us. And it's very uncomfortable to continue to have, rashes and hives. For instance, if I touch plastic bags on my arms, like the shopping bags, if I carry one, if it gets to, I will break out in rashes and almost welts. So keep an eye out for these things. Watery. Here's another one: the watery eyes when you're choking, and it's just a choking that's not really, red alert, but you're having trouble, the eyes will water as well. And people can't communicate. We know that, don't we? Right. So then there's, you can ask, if you see a swelling on someone's face, you can sort of say, oh, is there any tingling or anything going on? You can ask as much as you possibly can. The wheezing and coughing, something's gone down there. Or with a food, it means that the histamine has been released and the allergy process is in place. That's not intolerance, that's allergy occurring and there's wheezing and coughing. And I know, like, it must sound like I'm a walking medical disaster. But I have this anaphylaxis to eggplant, which was my favorite food. And that's the thing: when we eat too much of something, we can build up such a, and I had an anaphylactic reaction to eggplant. And it's a really horrible, 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 horrible thing to happen. I had to go straight to the hospital. So I'm really, be really mindful of what you're seeing with people. Of course, there's these intolerances and that less severe thing, which is where people may throw up. They may get stomach aches, they may get diarrhea from, so looking at how much time people are spending in the bathroom, they're, in SIL, like bowels opened, what was it like, that sort of thing, because food makes a very, very big impact on the body. Anaphylaxis, not much fun. So I'm not going to go into that area because there's other training around anaphylaxis and allergy. Like we have allergy training, recognizing allergies, recognizing anaphylaxis, and then there's the anaphylaxis. What do you do, etc. So I'm not going to go into that. I'm just mentioning that these are some of the things that people would need a professionally written mealtime management plan. Okay, so the intolerance flags. Stomach pain, bloating, gas, diarrhea, nausea after certain foods. Some people will get constipated. There was a person who died in a SIL home from a blocked bowel. It just kind of shouldn't be happening, like that must have been someone would have not have emptied their bowels in quite a long time for that to happen. People with you get indigestion, these reactions, migraines and headaches can do it. So there are things that people will be able to tell you about and things that they won't. I'm not saying that you have to be the all-seeing, all-knowing when somebody has communication deficits. I'm not saying that at all. Just do the best, and you absolutely can. It's do the best you can to be looking, smelling, noticing, seeing, or all of those things. Be watching those people that you're caring for. Why does it matter? Even though intolerants are life-threatening, they can reduce the quality of life substantially. Report patterns to your supervisor straight. Same thing as I said before. And if nobody acts, then it's a good thing to step up yourself and make an external report. You've got other eating disorders. You may not see that quite so much, but I'm sure you'll have some. You'll have people who restrict in terms of anorexia, and then you'll have people who will eat a lot and then throw up. So we would always look for people going after, well, what would you look for if somebody's got bulimia? What would you see? What would be your first hint that somebody, maybe not first yet, but what would be your first hint around a mealtime that somebody might be experiencing bulimia? Come on. What are you going to say?
Got Andrew trips to the bathroom.
Absolutely. After the meal. Yeah.
Yeah, we've
it could
got
be, yeah.
we have Colby go to the bathroom after meals, bringing and going to the bathroom afterwards from Lou
Good.
in dental. Yeah.
Yeah. Good. And look, you'll often see that with, probably not with intellectual disability. I'm not saying never. I'm just saying it's probably more prone to people with mental health issues. So, so you may see that in those situations. So keeping your eye out for those. There'll be a lot of restricting, there'll be skipping meals, significant weight loss or underweight, intense fear of weight gain, distorted body image, rituals, cutting the food up into tiny pieces, chewing it very slowly, making it go as long as possible. You might see physical signs. You will see when anorexia gets to a severe state, of course, but there's all the times along the way. The fatigue, the dizziness, the cold, the intolerance, and a disrupted menstrual cycle. Bulimia nervosa, episodes of binge eating, large amounts, sometimes in secret, sometimes not, often fast. Purging behaviors, you'll see that overuse of laxatives, focus on exercise to remove calories, basically. They may have swollen cheeks. Now, I don't know if you knew this or not, but bulimia is quite easy to see from a dental perspective because the acid from the vomit actually does take away parts of the tooth's enamel. So that's easy to see. You'll often also have there'll be bad breath and and things like that. But, you can't miss somebody going to the bathroom unless they've got their own bathroom. There'll be weight fluctuations, mood fluctuations as well. And well, this does need, an urgent referral. I would say it's probably in the lesser degree than what we just, talked about with the other pages, but it's still around, and we still do have a 60% mental health quota. 60% of the people on the scheme are mental health. The overeating and gorging, I know that there are some diagnosis groups that have problems with food, but we can't talk about that. All you need to do is observe it. And of course, there could be more in some of those situations. There will be more than just a mealtime management plan needed. There will possibly be behavior support plan as well. But noticing, this is just about the noticing, picking it up, documenting it, telling someone. These are the main things for you to remember, that you want to pick up these things. It matters because a mealtime plan may involve very scheduled snacks to try to, stop this or reduce this occurring. And the person will, probably require some ongoing psychological support. Then we've got our mealtime management due to diabetes. So you'll be looking, now remember, not everybody comes to you with that diagnosis. These diagnoses come over time at times. So, the excessive thirst and urination, extreme hunger even after eating, unplanned weight losses, fatigue, irritability, confusion, all the normal signs of the sort of low blood sugar, approaching meal times. Blurry vision, that's at an extreme. You'll often see slow wound healing with somebody who's pre-diabetic or diabetic. And with slow wound healing, that means pretty much any wound. Yeah, so things will just take quite a long time to heal. Unstable blood sugars can be dangerous. If you observe these, say something. Remember, people aren't going to come to you with the package deal. These things are going to develop over time with many people. The cardiovascular health, mealtime management plans can be based, for cardiovascular health. People who have already started down the path of lifestyle disease, present, which is, people with blood pressure, high cholesterol. It's not to say that every person who's extremely overweight has an issue, but a lot of people will. So, when you're seeing someone who's extremely dangerously overweight, or you can see that, their diet's not good, and, down the track that may not look good, it's good to speak up. We're not trying to stop people doing what they want. We can't do that. But it is our job as the person responsible for the care to document it, to mention it, to do everything that you can, that's in your power, to be able to not contribute to that person's discomfort and early mortality, but to contribute at least as best you can to them having a quality of life. There will be times when support workers will be asked to record blood pressure readings for people who have cardiovascular health issues. You will notice things like, and I have met people who don't speak up when there's swelling of both ankles or swelling of one ankle from fluid retention. So you want to be looking at all of these unusual things and speaking about it. Always thirsty, maybe they've got a lot of salt in their diet, watching what people are having in their salt, and how much salt people are having, is it's okay if that's their choice. But do they also have, are they also on a cholesterol medication and a blood pressure medication, and they whatever other issues they might have? So it's sort of our job to at least be documenting it, trying to do the best we can to help them improve that. That's all we can do. obviously goes needless to say, people have chest pain or breathlessness, and weight gain. All of these things are observational things that you can be noticing about the person who's in your care. And you're not a nurse. Nobody's expecting you to be a nurse unless you are a nurse, and you're employed as a nurse. But nobody's asking you to be a nurse. It's just asking you to be observational and notice these things. So the mealtime plan can help to reduce that, that salt and that fat, etc., and that will improve people's overall health. Other signs that may require a mealtime plan. When you can see malnutrition, there's weight loss, fatigue, frequent illness, slow healing. That's a sign of malnutrition. Now, it could be from a bodily health, from the head, from the head down, from below the head. Could be amazing things there. But please don't forget that if you're not chewing your food, your body can't extract the things that it needs to, and it'll go straight through your body. So I think we need to also remember, and it's not because I'm a oral health evangelist, I mean, it's just sensible. If you can't chew, you can't get the nutrition that you need, and you can choke. So just remembering those things, and that people should be going to the dentist every 6 months. I can't speak to people who have behavioural issues and you may not be able to get them there. That's another issue which you can deal with the right people. But the rule is every 6 months people should be going to the dentist.
We have,
Yeah,
sorry, Gina. Sorry to
no,
cut
no,
you off. We
don't be
have
sorry.
a comment from Robin about the bulimia. We had a participant who had bulimia and she didn't allow us to fill weekly diet chart because she felt it intimidating, so it becomes difficult to assist and share updates to relevant healthcare professionals.
Yeah, to be honest with you, I don't think that she can stop you. She can stop you um, giving her food she doesn't want. She can stop you doing all sorts of things, but what she can't stop you doing is filling out a sheet, a form, because that's your job. Like, there's
Um,
choice and control. There's choice and control, sure, but like, then there's your job. Like, she can't stop you. Anyway, tell everyone, Robin, because it's always helpful.
yeah, Gina, just wanted to ask first that obviously she cannot refuse it, but then when she's saying that she's not updating us or what she's eating or what she doesn't want it to write and showing the behaviors of concern, and then using all these jargons to make sure that that you can't do things without my consent. So in that way,
Mm,
it becomes intimidating for us as a provider that what can we do because we want to support it, document things as well. We do recommend the staff to just note it down if they refuse to do it. But
yeah.
yeah, just thought of sharing this thing because we are discussing about this topic.
Yeah,
So
it's
yeah.
difficult, isn't it? Um, yeah, like I say, they cannot stop you writing anything because that's your job, and they sign that client or their guardian signed up for that. Um, but yeah, if she doesn't want to participate in that, there isn't anything that you can do beyond that. But you can write it down, and you can, make um notations and say, this is worse, this is what we think. Obviously, what she does with that, or her guardian, or her support coordinator, is then up to her. But yeah, she can't stop you writing it. Yeah, what can you do? I would though be wanting a I would be wanting a I wish I could think of the name. The dignity of risk form, I would want clearly articulated that she doesn't want help with this, and someone has to sign it. So that's up to her. But you know, um, you've got the risk assessment. You continue to keep documenting the risks. But if she isn't accepting any of that help, I would want that dignity of risk form filled out. So yeah. Um, so yeah, like we talked about, malnutrition, dental issues, cognitive behavioral eating issues, too fast, stuffing your mouth. Obviously, that goes into other areas and diagnoses, but we're not here to do that. We're just here to talk about what are the things that you could see with a person in SIL or community where there possibly is a need for a mealtime management plan and it's not there yet, okay, because they're emerging. Of course, celiac disease, kidney disease, blood thinning interactions. A lot of this stuff we can pick up at assessment, but some of it will emerge, and that's the issue. Physical support needs with the utensils and fatigue. Of course, these will be things. If you're noticing someone can't use their utensils, or they're too tired to finish their eating, it might be time for a referral for a mealtime management plan. And of course, there are clear rules for escalating. Emergencies, triple O. You do the best you can on the ground with what you know. Any red flags from above, you tell your supervisor straight away. We talked about that. You document it, you do the best you can. And if you feel that your person above you, who you rely on, isn't acting at all, like not at all, and you know that, then it's time to maybe give them an opportunity to not do that, or to actually act, or I would just report them and not say anything. That's what I'd do. You don't have to get yourself into any pickle with anyone. It's too hard. Just remember, mealtime management plans are not written by non-professionals. Okay, now I have taken so long doing that, but I want to get to the next bit. I think I'm going to give you this, so I think you'll be fine. You'll be able to read through the recap because we've nothing that we haven't already talked about. But what I wanted to touch on, and there's all what I wanted to touch on was, because what I said is, have I not got the, where's my mealtime, am I in the, Sheila? I need to, I'll just talk to it. I don't need the PowerPoint. Right, what I wanted to talk about, and I do have it in PowerPoint slides, is if there's no mealtime management plan needed, is there anything needed? Is that like there's none of this going on, so I don't need anything. Is that an accurate statement? I'd love you to jump in, guys. Is that accurate then? If none of this is going on, we don't need anything at all. If we're in a supported independent living home or assisting people in the community or in their own homes at meal times and stuff like that. Sheila, can you read to me?
We've got eating and drinking profile from Robin.
That's it. Yeah. So what else is there? I could see a few comments going there. Is there anything else that anyone's
We
saying?
have it should be easily accessible at home all the time. Still from
What does that
Robin.
mean? What? Oh, right. So that's still on Robin's comment. Yeah.
Yeah.
Has anyone else got anything to say about mealtime management? And if there's anything needed, if we don't need if none of this if none of what's going on with anyone meets the threshold of I don't know what that noise is, but meets the threshold of a mealtime management plan, does that mean we don't need anything? That's my question. Has anyone got an answer?
So we got audited by the NDIS during the mealtime management plan. So that's where one of their observation and comment was that make sure that it's easily accessible at home. That was a question raised by Wendy, though. That Wendy asked that do we need to have accessible mealtime plan in the house? So it should be accessible to the staff.
Absolutely. The mealtime management plan needs to be accessible. It would be advisable to turn it into a training module. and then just update that as the mealtime plan updates. But that's the question is, if no one in your care at the moment requires a mealtime management plan, does that mean nothing else is needed?
No, so we do have an eating and drinking profile. We
Correct.
implement
Do,
that,
do you want
and
to tell
that's where.
everybody what that is, Robin?
Yeah, it's like a profile which talks about the eating and drinking habits of the participant. What do they like to eat? What are their foods? So that gives a brief overview to the support workers who are supporting them. And that's where we also had this confusion. We first thought the mealtime management is meant for everyone. Like, I
Mm.
mean to say that's the document because it says mealtime, but obviously when you go in the depth of
We've had to
definition,
change the wording.
yeah,
Yeah,
yeah. So
yeah.
that's where. So then we got a clarity that those who have difficulty in
Mm,
swallowing the food for some reason, they
mm,
need to have a mealtime management plan. And the
mm.
others who do not have, they all should have everyone should have an eating drinking profile apart from,
Correct.
yeah.
Yeah. So
Yeah.
that's the thing, guys, that I wanted to get to. How do you know when somebody needs a mealtime management plan? We've looked at those issues that might arise, that would need a professional mealtime management plan. But everybody in a supported independent living home, or that you are looking after for and doing meals for in their own home, or taking them out extensive periods of time. And by extensive, I mean if you're doing any more than like 4 hours with the same person in one week, but it includes a meal, you need to know something about them, you know, just something about them. And if there's nothing much to see here, once you've done it, great. But that's not always the case. And this is where you might find some of those and be able to monitor some of those emerging things. Yeah. Um, we need to know what their cultural preferences are. We need to know how they like to eat. We need to know, like we all did this before the NDIS. We wanted to know where they wanted to eat, how they like to eat, what are your cultural preferences. And when I say that, I mean not just if you are from some other country. You know, we've got to remember that we've got Australians here who like, I'm just going to say sausages and eggs. You know what I mean? Like, we're all different. And just, we Australians have a culture too. And we've got a lot of people who are not born in Australia delivering services to people who are now aged or have disabilities, etc. Everybody has a culture. Maybe people like to sit here or sit there or do it this way or that way. We need best practice. There is nothing in the NDIS standards that says you need to do a my eating and drinking profile, or that you need to do this nutrition and food and food and drink, or food and nutrition, whatever it is. We're just redoing ours now to simplify it and update it. But there's nothing to say that you have to, but it isn't the right thing to have a SIL client that doesn't have that. And if you're doing a great deal of work with someone in their own home or community, you should also have that too. It's just the right thing to do, but it's up to you. There are people I know who would just never dream of not using it, because how can you possibly know what people like if it's not in something somewhere for somebody to read? I just don't think it's possible. Yeah, anyway, I think that kind of brings me to the close of how you recognize when someone needs a mealtime management plan. And I think you can recognize who needs a my eating and drinking profile, or we could call it a food and nutrition profile. Just so you know about people's likes and dislikes, that one is non-medical. So, are there any questions at this point?
We have a question from Toyin. Is there a good template that can be used?
Um, I'm just
Uh,
about to redo ours. We took ours from the Aging, Disability and Home Care New South Wales, my eating and drinking profile, because it stood the test of time. I think I'm just because I've got time, I'm going to actually reduce it and try to make it a little bit more simple. Um, I don't really know of any as on the market at the moment. But because it's not what's the word, mandated, as long as you included a lot of those things that I talked about, which was culture, where, how, what nights would you like to go shopping with us? Do you want to cook with us? Etc. It could be anything you want it to be. You can check back with me in a couple of weeks and see, when I finish the revamp of um our our current one. But yeah, I mean, it is open to innovation. You could just put one together, or you can check back in with me then. Wouldn't even be surprised if you would find one if you just Googled that as well. So really great thing to have, and it doesn't have to be War and Peace. It doesn't have to be a book like War and Peace. Just needs to be something that you've got in
We have
acknowledgement.
another question from
Mm,
from Robin.
mm.
If a participant doesn't have funding for speech and dietitian, but we got nurses on board, would you recommend company taking risk to make meal management plan with nurse, or stick on getting the support coordinator to get the funding sorted and engage with the relevant professionals?
I would get the nurse to put an interim one together if the support coordinator can't access the funds for that necessary allied health professional from another budget. And I would think that they're not doing a mighty job if they can't, for something as urgent as that. I would be really disappointed if they couldn't A, expedite it, or B, organise in, find out if it's, if they can use another budget, and even C, make a blooming quick email of urgent nature to the NDIA to say it needs to happen pronto. Make it happen. How do you want to do that? Yeah, you can do the interim if I think do the interim anyway, but be very careful. Any other questions?
None so far.
Okay, well, I hope it's been helpful. Just out of interest, most people in the room, are you manager level, or are you owner, operator? What's the kind of attendee interest? Who's it coming from?
Andrew is a behavior support practitioner.
Oh, hello.
Wendy is a nurse advisor and educator.
Excellent.
We've got
Oh,
Lou,
great.
activities and programs coordinator. Tina,
Fantastic.
owner
Yeah,
and support coordinator.
great. Oh, that's fantastic. Good. Okay, get out there and educate people and help them to understand what they're looking for, and help owners and operators and team leaders understand that those support workers are their eyes and ears. And how can you collect this information? Excellent. Thank you, everyone, for coming. We'll send out the recording to you. It'll be available for, I think we keep it keep it active for 14 days. Yeah. Thanks for coming along, everyone.
Thanks, everyone.
Have a good weekend.
The recording, Gina.
Okay, good idea to turn that off. And it's, I've got to find it first, Sheila. Where am I? I'm so not used to being on a Mac. Pause stop recording. There we go.